Welcome to the deep dive. We are embarking on a journey into, well, the absolute core of understanding surgical patients, the foundational skills of history taking and physical examination, specifically when someone comes in with problems in their abdomen.
Yeah, and this isn't just a casual look. We're drawing from excerpts of Bailey and Love's Short Practice of Surgery, a text that has, guided generations of surgeons. Our goal is to go beyond just knowing what the signs and symptoms are and really grasp the art and the science behind uncovering them.
Exactly. Our mission in this deep dive is to unpack these fundamental clinical techniques so thoroughly that you start thinking like an expert clinician faced with an abdominal mystery. We want to understand the why behind symptoms, the logic behind the examination steps, and how elite professionals build their understanding from the ground up. It's about gaining that deep structured knowledge.
Think of it as learning the master craftsman's approach, right? Before the complex tools come out, they rely on their senses, their knowledge of materials, and their ability to observe and interpret. In surgery, the history and exam are those fundamental skills.
And the text makes this point absolutely clear right at the outset. There is no substitute for a detailed history and a thorough clinical examination. None.
It's a critical principle, maybe even more so now. With the incredible sophistication of diagnostic tools like ultrasound, CT scans, MRI, the temptation is always there, isn't it?
Yeah.
To sort of bypass the patient interaction and jump straight to imaging. But the book stands firm. You must resist that temptation. The clinical assessment comes first.
Because that initial interaction, listening to the patient, examining them, that's where you start building your list of potential diagnoses. It guides which investigation you might need, or maybe even tells you that imaging isn't the urgent next step at all.
Right. Skipping this foundational part can send you down an expensive, time-consuming, and potentially misleading path.
Precisely. And it's crucial to remember the limitations of modern practice, too. Things like telemedicine, remote consultations, they have their place, undoubtedly.
For sure. But as the text highlights, you simply cannot perform a physical examination over a video call. It's just not possible.
Which means if the story the patient is telling you, based on the history alone, raises the possibility of something serious or urgent that requires you to feel their abdomen to palpate, you absolutely have to see that patient face to face. There's no way around it.
Yeah. Failing to transition from a remote consultation to a physical one when it's indicated is a major risk. You could easily miss a potentially life-threatening condition that needs immediate surgery, or because you couldn't feel what was happening inside. The physical exam isn't just, tradition, it's a vital diagnostic filter.
Okay, so picture it. The patient is there, you're face to face. The text points out that the assessment doesn't actually begin when you start asking formal questions. It starts the moment you first observe them.
That's a key insight, isn't it? Experienced clinicians are gathering information from the instant they see the patient walk in or, how they're lying in bed. It's nonverbal communication that provides immediate clues.
Like their general appearance. Do they look comfortable and well, or do they look obviously sick, maybe pale, sweaty, unwell?
Or their gait, how they walk. Are they sort of bent over, shuffling, moving really guardedly? That immediately suggests abdominal pain.
And if they're already in bed, their position can be really telling. Are they lying perfectly still, rigid, almost afraid to move an inch?
Yeah, that suggests peritonitis, that widespread inflammation inside. Or are they maybe curled up, perhaps rocking back and forth? That's often more typical of colicky pain like kidney stones or bowel obstruction where movement might offer fleeting relief, where they're just trying desperately to find a comfortable position.
Facial expression, too. That's another crucial instant read. Pain, anxiety, fear, discomfort. It's often written right there on their face before they even say a word.
Absolutely. Even their tone of speech can indicate their level of distress, maybe weakness, or the effort it's taking them to communicate through the pain.
Thinking about the patient's state, especially in an acute situation, they're likely anxious, vulnerable, possibly in severe pain. This isn't just a physical encounter, it's deeply human.
And the text strongly emphasizes this. Before you even get into the, let's say, clinical interrogation, the clinician needs to introduce themselves, make a conscious effort to comfort the patient, to gain their confidence, and put them at ease. Ensuring privacy is just non-negotiable.
Right.
And if the patient seems uncomfortable or hesitant, maybe because of the symptoms or cultural reasons, offering a close family member to be present as a chaperone is a simple but really important step.
Beyond the ethical and compassionate reasons, why is putting the patient at ease so fundamentally important for the physical examination itself?
Well, because the accuracy of the abdominal examination really hinges on the patient's abdominal wall being relaxed. If the patient is tense, scared, or uncomfortable, their abdominal muscles will be guarding, tensing up. Trying to palpate through rigid, voluntarily contracted muscles is incredibly difficult and can completely mask underlying findings like subtle masses or localized tenderness. It almost renders your examination useless.
So, building rapport and trust directly impacts your ability to make a diagnosis through physical touch. That's a powerful connection, isn't it, between the art of communication and the science of examination?
Absolutely. And it's a significant challenge in those high-pressure, busy environments like an emergency department where time is short and anxiety is high. Mastering the ability to quickly establish that rapport and help the patient relax it's really a hallmark of an experienced clinician.
Okay, you've observed the patient, made them as comfortable as possible, building that foundation. Now it's time for the formal history. How does the text recommend starting?
The starting point is, well, it sounds simple, but it's incredibly effective. An open-ended question. You invite the patient to tell you, in their own words, why they are seeking medical advice. Something like, what's brought you in today? Or maybe, tell me about the problems you've been having.
And the critical instruction that follows: listen.
Without interruption. Yes. This is where we really see the wisdom in Sir William Osler's famous quote, listen to the patient, he is giving you the diagnosis. It's so easy to think you know where they're going and jump in, but if you just let them speak, they will often volunteer the most crucial piece of information without you having to specifically ask for it. Their narrative provides that initial framework.
Okay, so once they've finished their initial story, then you use carefully directed questions to refine the history.
Exactly. These questions are guided by what you've just heard, helping you clarify points, explore details, and start focusing on the likely organ or system involved.
It's a dynamic process.
Yes, the history-taking is dynamic. You're listening, forming hypotheses in your head, and then asking targeted questions to test those hypotheses, sometimes moving forwards and backwards through their timeline as needed. However, and this is important, the record of that history, the written note, should always be structured logically for clarity and completeness.
Let's dive into those common presenting features, starting with acute situations. The text states that pain is the most common abdominal symptom.
Oh, without a doubt.
Mm.
And when pain is the main complaint, your job is to meticulously establish its characteristics. The classic features you need to ask about are paramount. The exact site of the pain, where is it worst? Does it stay there? Point to it.
Yeah.
Then the nature of the pain, is it constant and dull, sharp and stabbing, cramping and wave-like, colicky?
Right, the quality.
Exactly. The onset, did it start suddenly, like flipping a switch, or did it build up gradually?
Yeah.
The duration, how long has this episode been going on? Have they had similar pain before? The radiation, does the pain move or spread anywhere else in the body, like the back, the shoulder, the groin? And critically, any aggravating or relieving factors, what makes the pain worse?
Yeah.
Does anything make it better, like food, position, medication, vomiting?
Getting all those details provides such a rich picture of the pain itself, which is often the primary clue, isn't it?
It absolutely is. Now, in non-acute situations, the symptoms are different, but just as important to detail. Lack of appetite, anorexia, unexplained weight loss, jaundice, that yellowing of the skin or eyes, changes in bowel habit like constipation, diarrhea, frequency changes, any blood loss, maybe in vomit or stool, or just generalized fatigue that might point to chronic issues like anemia. Each of these needs careful, directed questioning to understand fully.
Moving beyond the immediate symptoms, the past medical history is presented as vital.
It absolutely is, because it can directly influence both your diagnosis and how you manage the patient. The text gives excellent examples. If someone has had previous abdominal surgery, especially a laparotomy, a large incision opening the abdomen, you immediately have to consider adhesive small bowel obstruction as a cause of their current pain and vomiting. Adhesions, that scar tissue from surgery, are a really common culprit.
Makes sense. Or if someone has a known history of diverticulitis, particularly on the left side, and they come in with left iliac fossa pain.
It's highly likely related to their known condition, right? You have a strong starting point.
And critically, the source of abdominal pain might not even be in the abdomen.
Exactly. The text highlights conditions outside the abdomen that can mimic abdominal problems,
Yeah.
like abdominal pain in sickle cell crisis, which is a hematological disorder, or acute epigastric pain, sometimes seen in diabetic ketoacidosis, DKA, a severe metabolic issue. You really need to have a broad perspective.
Another example given is recurrent right iliac fossa pain. While acute appendicitis is often top of mind, especially the first time,
If they have a history of Crohn's disease, or if you're in a region where it's more common, Conditions like amoebic typhlitis or ileocecal tuberculosis become strong possibilities. Knowing they've had TB in the past would be a major diagnostic steer, wouldn't it?
Definitely.
And the text correctly points out that obtaining previous medical records and investigation results, while sometimes difficult, is well worth the effort for this historical context.
Next up is drug history and allergies. How critical is this for abdominal complaints?
Oh, incredibly important for both symptom interpretation and perioperative management. Medications can alter how symptoms present. For instance, a patient with significant internal bleeding might normally have a rapid heart rate, right? Tachycardia.
Yeah.
But if they're on a beta blocker, their heart rate might be deceptively normal, masking the severity of their blood loss.
That's a key detail that could really mislead you.
It's exactly. Or consider a patient on long-term corticosteroids for, say, asthma or rheumatoid arthritis. If they need surgery, their adrenal glands might be suppressed, meaning they can't produce enough natural stress hormones. They would require carefully managed IV steroid supplementation around the time of surgery to prevent a potentially life-threatening adrenal crisis.
Wow.
Similarly, patients on anticoagulants, blood thinners, will likely need reversal before surgery to prevent excessive bleeding.
And managing diabetes.
Diabetic patients require very strict glycemic control, usually using a sliding scale insulin regimen around the time of surgery. High blood sugar impairs healing and seriously increases infection risk. And of course, a thorough inquiry about any past adverse reactions to anesthetics or other medications is absolutely essential for planning safe care. Don't want any surprises in the operating room.
The social history section seems maybe less directly clinical at first glance, but the text includes it.
It's vital for a holistic picture. Factors like significant alcohol use, illicit drug use, smoking history, and their occupation can be directly relevant to certain diagnoses or risk factors. Think about pancreatitis and alcohol, for example.
Right.
But it's also about understanding their support system. Knowing their family background and the domestic support they have is crucial for planning a safe and successful discharge after potential surgery. Can they manage their recovery at home? Who will help them? These are practical, important questions.
And family history can reveal genetic predispositions, obviously.
Yes, it's important to ask if family members have had similar or related conditions. This includes cancers, inflammatory bowel disease like Crohn's or ulcerative colitis, or maybe endocrine diseases like hyperparathyroidism, which can cause recurrent kidney stones or abdominal pain due to high calcium levels.
Asking about genetic disorders or known familial adverse reactions to anesthetics is also a critical safety measure.
Okay, rounding out the history is the review of systems. This is essentially a systematic check for problems in other major body systems: cardiac, vascular, respiratory, endocrine, renal, etc. The text underscores that these coexisting conditions, or comorbidities, can have, and I quote, grave implications for surgical safety. Someone with severe heart disease or lung disease might not tolerate anesthesia and surgery well, and you absolutely need to identify these risks up front.
So pulling all that together, the principles of history taking, as laid out in the text, form this really structured process. You identify the reason for the visit, the presenting complaint. You get the precise details of its onset, duration, evolution. This helps you deduce the likely organ or system involved.
Which you then refine with those targeted questions.
Right. Then you layer on the essential context, past medical, social, family, drug, and allergy history, and check for other health problems through the review of systems. With all that information gathered systematically, you can then formulate your initial list of differential diagnoses.
It's a systematic accumulation of clues, isn't it?
Oh.
Filtering possibilities as you go. That's the core of clinical reasoning based on history.
Now, how do abdominal problems typically manifest clinically? The text lists the common ways they present themselves.
Yeah, the common presentations are pain, as we've discussed, weight loss, anorexia or vomiting, jaundice, abdominal bloating or distension, feeling or maybe even seeing a lump, changes in bowel habits, and signs of blood loss or anemia.
And there's a specific caution mentioned about subtle presentations, particularly concerning malignancy.
Yes, and this is crucial. Cancers aren't always painful or obvious in their early stages. The text gives some classic examples of these more insidious presentations. A right colon cancer might first show up simply as unexplained anemia due to chronic, often unseen, blood loss.
Just tiredness and pallor.
Exactly. Metastatic liver cancer often presents with weight loss without much abdominal pain initially. Gastric cancer can cause loss of appetite anorexia before significant pain develops. Ovarian cancer might present initially with increasing abdominal distension that patients might even mistake for simple weight gain. and malignant obstruction of the bile ducts classically presents as painless jaundice. Being vigilant for these less dramatic presentations is absolutely key.
Let's deep dive back into abdominal pain, given it's the most frequent symptom.
Right, pain is the great interpreter of abdominal pathology, you could say. It can arise from so many different processes.
Hmm.
Inflammation like appendicitis or cholecystitis, infection, obstruction like a bowel blockage, problems with nerves, neurogenic pain, tumors, neoplastic causes, or lack of blood flow, ischemic pain.
And sometimes even after a thorough investigation, you don't find a clear organic cause, leading to that diagnosis of functional or nonspecific abdominal pain.
The text acknowledges this category. Conditions like non-ulcer dyspepsia or irritable bowel syndrome, IBS. But it also points towards, the exciting area of ongoing research into pain pathways and the gut microbiome. It suggests that our understanding is evolving, and what we currently label functional might actually have more precise biological explanations in the future. It mentions Chapter 73 for more on that.
Going back to the details of pain site, nature, radiation, onset, associated features, the text uses these characteristics to paint really vivid pictures of classic pain syndromes.
Take biliary colic, typically caused by gallstones.
Right.
The pain is classically in the right upper quadrant, the RUQ, and often radiates around to the back, specifically the angle of the right scapula, the shoulder blade. It's also frequently associated with food intake. Why?
The gallbladder contracting.
Exactly. Eating, especially fatty food, releases the hormone cholecystokinin, which signals the gallbladder to contract and release bile. If there's a stone blocking the cystic duct, that contraction causes an intense pain as the muscle tries to squeeze against or past the obstruction. The trigger tells you something about the organ involved.
Fascinating. And acute appendicitis, that classic shift.
But has that famously migratory pain. It often starts as vague pain around the umbilicus, the belly button. There's that midgut-derived, poorly localized visceral pain we'll talk more about. But as the inflammation progresses and irritates the parietal peritoneum in the right lower abdomen, the pain shifts and localizes sharply to the right iliac fossa, RIF, often near McBurney's point. That migration is very, very characteristic.
Acute pancreatitis sounds like really intense pain.
It typically is. It's usually an abrupt onset of severe pain located centrally in the epigastrium, often described as boring or going straight through to the back. And the text points out that this pain can be difficult to distinguish from other severe conditions like a perforated peptic ulcer or even a leaking abdominal aortic aneurysm, which emphasizes the need for a broad differential diagnosis and careful assessment.
And intestinal colic from bowel obstruction.
This is most often felt as that colicky, cramping pain around the umbilicus again, that midgut distribution. It's caused by the bowel muscle contracting forcefully against an obstruction. This pain is usually accompanied by abdominal distension. And a key clue is that the distension is typically more marked the further down the obstruction is in the bowel. Makes sense, right? More bowel filling up behind it.
Yeah. And the associated symptoms differ too, depending on location.
Absolutely. If the obstruction is high up in the small bowel, vomiting is often an early and prominent feature because everything proximal to the blockage just comes back up. If the obstruction is lower down, especially in the colon, absolute constipation, the inability to pass any stool or gas is usually an early and critical sign.
Finally, renal or ureteric colic caused by kidney stones.
This is often described as excruciatingly intense pain, usually starting in the flank, the side, and radiating downwards towards the lower midline, the groin, and in men, often into the scrotum. This pain is almost always associated with either visible blood in the urine, macroscopic hematuria, or microscopic blood that you can detect on a urine dipstick test.
It's really remarkable how much diagnostic information is embedded just in the description of the pain if you know what to ask and what patterns to listen for.
The history is truly your most powerful initial tool, no question.
Let's shift now to altered bowel habit. Changes here can range from minor inconveniences to signs of really serious disease.
Right. The key in the history is to get specific details. When did the change start? Onset. What is the nature of the change? Constipation, diarrhea, increased frequency, urgency. How long has it been going on? Duration. And how does it relate to any abdominal pain the patient might be having? This helps differentiate between functional problems like IBS and organic pathology.
The text notes that patients might define diarrhea differently, which is a good point.
Yeah, exactly. You need to clarify. Do they mean truly loose, watery stools? Or are they simply having bowel movements much more frequently than their usual pattern, even if the consistency is relatively normal? It's an important distinction.
And there are specific patterns that help distinguish irritable bowel syndrome, IBS, from structural problems like cancer or IBD.
Yes. A common pattern suggestive of IBS is a long-standing history of increased stool frequency, often associated with left-sided abdominal pain that characteristically occurs before they have a bowel movement and then eases after they've emptied their bowels. This pattern relates to the altered motility and visceral hypersensitivity in the gut seen with IBS.
But if those symptoms increased frequency, pain perhaps relieved by defecation are of recent onset.
That's a potential red flag. If those symptoms have just started, especially if there's also blood or mucus mixed in with the stool, then you're much more concerned about organic pathology like a colonic carcinoma or inflammatory bowel disease. Those possibilities definitely need urgent investigation. Recent change is key.
The text also describes the presentation of acute on chronic intestinal obstruction. What does that look like?
This scenario often occurs in older patients. They might report a history of gradually worsening constipation or a change in their bowel habit over weeks or months. That's the chronic part. This then suddenly culminates in severe abdominal pain, marked distension, often vomiting, and absolute constipation. That's the acute part. This presentation is highly suggestive of a stenotic lesion, a narrowing in the left colon, which is very often a cancer causing a progressive blockage that finally becomes complete.
And there's a particularly urgent sign to look for in obstruction, isn't there?
Yes, and it's absolutely critical to recognize. If a patient with suspected colonic obstruction has marked abdominal distension, and they have significant tenderness specifically over the cacal area that's the beginning of the large intestine, in the right lower abdomen, this suggests a closed-loop obstruction with impending cacal rupture.
Can you explain that closed loop mechanism again?
Sure. If there's a blockage further down the colon, say in the sigmoid, but the valve between the small intestine and the cecum, the ileocecal valve, is competent, it acts like a one-way valve. It stops the colonic contents from backing up into the small bowel. So the colon becomes a closed loop that can't decompress backwards. Pressure builds up dramatically inside this closed loop, and the cecum, being the widest part of the colon and having the thinnest wall, is the most likely point to stretch and eventually rupture or perforate. Tenderness there is a sign that it's under extreme strain and about to give way.
That sounds like a surgical emergency.
It is an absolute surgical emergency. The text also briefly mentions ileocecal tuberculosis, which can present as a mass in the right iliac fossa and sometimes causes an audible ball of wind and gurgle, suggesting a narrowing, an ileal stricture caused by the TB.
So just to quickly reinforce some of those classic urgent presentations the text really highlights, patients with new onset pain and altered bowel habit require careful assessment to rule out urgent obstructive or inflammatory pathology. That sign of marked distension with tenderness over the right iliac fossa or cecum points strongly to impending cacal rupture and a closed-loop obstruction. Remember that cacal and ascending colon cancers often present with anemia due to chronic blood loss, sometimes with no other symptoms. Always consider adhesions in someone with previous abdominal surgery. And never, ever forget to meticulously check for small incarcerated hernias, particularly femoral hernias, which can be easily hidden in the groin crease, especially in obese patients where the abdominal panniculus, that apron of fat, might obscure them.
Those are absolutely vital checkpoints for any clinician assessing abdominal pain. Don't miss the hernia.
Now, let's really dive into the why behind all this. The pathophysiological basis of these symptoms and signs. Understanding the nerve supply seems fundamental, as the text explains.
This is where anatomy directly translates into clinical presentation. It's fascinating. The abdominal wall and the parietal peritoneum, that's the tough membrane lining the inside of the abdominal cavity, are supplied by the somatic nervous system. Think of this like the nerve supplying your skin. It gives precise sensory information. So, pain arising from irritation of the parietal peritoneum is typically sharp, well-localized, and easy for the patient to point to exactly where it hurts.
Okay, like the difference between bumping your whole leg vaguely and getting a small, sharp cut. You know exactly where the cut is.
Exactly that. In contrast, the abdominal organs themselves, the viscera and the visceral peritoneum, which is the thin membrane directly covering the organs, are supplied by the autonomic nervous system, specifically sympathetic fibers primarily. This system is more involved in regulating things like blood flow and peristalsis, less about precise sensation. So pain from these structures, visceral pain, is typically dull, aching, poorly localized, and much harder for the patient to pinpoint precisely. It's that vague, deep discomfort, often felt more centrally.
And the text explains how the pain changes as the pathology evolves.
Right. Initially, when an organ is just inflamed, stretched, or maybe experiencing ischemia, lack of blood flow, the pain is visceral. That poorly localized, dull ache, often felt in a general area corresponding to the organ's embryonic origin. But, and this is the crucial bit, as the inflammation worsens and the organ swells or moves to touch the adjacent parietal peritoneum, the pain pattern changes dramatically. The parietal peritoneum with its somatic nerve supply becomes irritated, and the pain becomes sharp, severe, and localizes precisely to the spot where the inflammation is touching that sensitive lining.
And this is where understanding embryonic development helps predict where that initial visceral pain is felt, that referred pain concept.
It's a classic principle. Visceral pain signals travel along sympathetic nerve fibers, which enter the spinal cord at specific levels. These levels correspond to the somatic nerve roots and therefore the dermatomes, the areas of skin supplied by those roots that supplied the body wall in that region during embryonic development. So the brain essentially interprets the visceral pain signals as coming from the corresponding somatic area on the body's surface.
Okay, let's trace those back to the embryonic gut sections mentioned.
Sure. The foregut structures, that's the stomach, the first part of the duodenum before the bile duct enters, the liver, the biliary tree, the pancreas, and the spleen. These were originally supplied by nerves entering spinal segments roughly T7 through T9. So visceral pain from these organs is typically referred to the epigastrium, the upper central abdomen.
Which explains why early stomach ulcer pain or pancreatitis pain is often felt right there.
Precisely. Then the midgut structures the rest of the small intestine, duodenum beyond the entry of the bile duct, jejunum, ileum, the caecum, the appendix, the ascending colon, and the first two-thirds of the transverse colon. These are supplied by nerves entering around T10, T11. Visceral pain from these organs is therefore referred to the periumbilical area right around the belly button.
Like the initial vague umbilical pain of appendicitis or small bowel obstruction. Got it.
Exactly. And finally, the hindgut structure, the last third of the transverse colon, the descending colon, the sigmoid colon, and the rectum are supplied by nerves entering around T12, L1, and L2. Visceral pain from these organs is referred to the suprapubic area, just above the pubic bone.
So knowing whether an organ developed from the foregut, midgut, or hindgut gives you a really strong prediction of where the early diffuse visceral pain will likely be felt.
It's a fundamental piece of the diagnostic puzzle. Now let's look at the somatic side again, the abdominal wall and parietal peritoneum innervation in a bit more detail as the text specifies.
Which nerves are involved there?
The skin and muscles of the abdominal wall are primarily supplied by the lower 6 intercostal nerves, T7 down to T12, which run horizontally around the body, plus the iliohypogastric and ilioinguinal nerves, which come from the L1 spinal root and supply the lower abdomen and groin area. These provide segmental innervation. It's helpful to remember the dermatome landmarks. T7 is roughly at the xiphoid process, the tip of the sternum. T10 is at the umbilicus, and T12 is just above the pubis.
And the parietal peritoneum gets its nerve supply from these same somatic nerves. That seems key.
Crucially, yes. The section of parietal peritoneum lining the abdominal wall, or the diaphragm, receives its nerve supply from the same segmental somatic nerves that supply the overlying muscles and skin. This is why when an inflamed organ irritates the parietal peritoneum, the pain becomes sharp and is accurately localized by the patient to the specific area on the abdominal wall corresponding to that segmental nerve. The brain knows exactly where that nerve comes from.
What about the peritoneum covering the diaphragm? That's a bit different, isn't it?
It is. The parietal peritoneum covering the central part of the diaphragm is innervated by the phrenic nerve, which originates way up in the neck from the C4 spinal level, mainly. Because the skin over the shoulder tip is also supplied by C4, irritation of the central diaphragm, say by blood from a ruptured spleen or a subphrenic abscess, a collection of pus just below the diaphragm, or even air from a perforated stomach, tracking up there is classically felt as referred pain right at the tip of the shoulder, usually the left shoulder for spleen issues.
So that explains the shoulder tip pain connection.
Exactly. The peripheral rim of the diaphragmatic peritoneum, however, is supplied by the lower intercostal nerves, so irritation there is felt more locally in the flank or lower chest wall.
And down in the pelvis.
The parietal peritoneum lining the pelvic cavity is mainly supplied by the obturator nerve.
Okay, so to recap the causes of visceral pain, it's typically from lack of blood flow, ischemia, muscle spasm, like in colic, or stretching of the organ or its covering. This pain is deep, poorly localized, and referred via sympathetic nerves to the corresponding somatic dermatome, somewhere in the T1 to L2 range generally.
Correct. And the critical clinical point, the thing to always look for, is that shift from vague, poorly localized visceral pain to sharp, well-localized pain when the underlying process evolves to involve the somatic innervated parietal peritoneum.
The text uses acute cholecystitis again as a perfect illustration of this transition.
It's a classic example. Initially, an inflamed gallbladder might cause that vague, aching visceral pain felt in the epigastrium or right upper quadrant, corresponding to its foregut origin. But as the inflammation worsens and the gallbladder wall becomes tense and maybe touches the parietal peritoneum lining the undersurface of the liver and the right upper abdominal wall, the pain becomes much sharper, more severe, and localizes precisely to the right upper quadrant. It can also radiate around the flank and to the back, following the path of those irritated segmental somatic nerves like T7, T8, T9.
And this mechanism directly explains Murphy's sign, right?
Absolutely. John Benjamin Murphy, an American surgeon back in 1903, described this sign. The parietal peritoneum in the right subcostal area, the overlying abdominal wall muscles, and the skin there are all supplied by the same spinal nerves. When you press gently in that right subcostal region and ask the patient to take a deep breath in, the diaphragm descends, pushing the inflamed gallbladder downwards directly onto the irritated parietal peritoneum under your fingers. This causes a sudden, sharp increase in pain, making the patient abruptly stop their inspiration. They catch their breath. That inspiratory arrest due to pain is a positive Murphy sign, a strong indicator of acute cholecystitis.
It's fascinating how that specific physical maneuver connects the anatomy, the physiology, and the clinical diagnosis so elegantly.
Isn't it? Another anatomical clue mentioned earlier, the child holding their right hip flexed with abdominal pain, also relates to muscle irritation. Retrocecal appendicitis, where the appendix lies behind the cecum, can directly inflame the nearby psoas muscle, which is a major hip flexor. Flexing the hip relaxes this muscle, reducing the irritation and the pain, so the child instinctively adopts this position for relief. This is sometimes called the psoas sign.
Let's return to obstruction pain specifically, contrasting the different types of colic in more detail, as the text does.
Right, that central periumbilical colicky abdominal pain remains the classic symptom of small bowel obstruction. Its location is due to the small intestine being a midgut derivative, referring pain to those T10, T11 dermatomes around the navel. The character of the pain, the colic, coming in waves is due to exaggerated peristalsis, those powerful muscular contractions of the small intestine trying desperately to force contents past the blockage.
And that wave-like pattern, how distinct is it?
It's very characteristic. The pain builds over maybe a few minutes to a peak, a crescendo, as a peristaltic wave hits the obstruction, and then it completely subsides for a few minutes as the wave passes and the muscle relaxes. That complete easing between spasms is a key feature distinguishing it from other types of colic.
How does that compare directly to biliary colic again?
Biliary colic, usually from a gallstone block in the gallbladder outlet, tends to have a more gradual onset, building over maybe half an hour or so to reach peak intensity. But critically, it typically doesn't disappear completely between spasms. There's often a persistent background ache or pain level, even when the intense cramping component subsides. The mechanism is different. It's less about waves of peristalsis and more about sustained pressure or spasms as the gallbladder contracts against a fixed obstruction.
And ureter colic from a kidney stone.
This pain, caused by a stone moving down the narrow ureter, is often described as arguably the most severe pain a person can experience. It's also colicky, but the spasms are usually shorter, maybe lasting only 1 to 2 minutes, and the location and radiation clearly follow the path of the ureter from the flank down towards the groin and often to the genitalia.
So, paying meticulous attention to the specific quality and pattern of the colicky pain, the onset, the peak intensity, the baseline pain between spasms, the duration of spasms provides really vital clues.
It absolutely refines your differential diagnosis before you even lay a hand on the patient. It's all in the details of the story.
Moving to another critical acute situation discussed, rupture and perforation of hollow organs.
Yes, the text specifically mentions the urinary bladder, the gallbladder, and importantly the gastrointestinal tract, the stomach, small bowel, and colon. These organs, of course, hold contents that are definitely not meant to be free-floating inside the abdominal cavity.
And if they rupture or perforate due to, say, trauma, lack of blood flow, or severe ulceration,
their contents leak out. For the GI tract, this includes things like digestive enzymes, bile, fluid, air, feces, and crucially, a very high concentration of bacteria. This spillage causes severe inflammation of the peritoneum, that lining of the abdomen, known as peritonitis, resulting in sudden, intense abdominal pain.
Does the pain stay localized to where the organ ruptured?
Well, initially, the pain might be most severe right at the site of the perforation. For example, a perforated peptic ulcer often causes sudden, severe upper abdominal pain. But depending on the organ and the extent of the leak, the contents can spread rapidly throughout the entire peritoneal cavity, leading to generalized peritonitis and widespread, excruciating abdominal pain. The patient is often lying stock still because any movement is agony.
The initial location of the pain, though, can still provide a strong hint about the source.
It can. If someone has a known history of peptic ulcer disease and suddenly develops agonizing pain focused in the upper abdomen, a perforated ulcer is extremely high on the list. Similarly, a sudden onset of pain localized to the right lower abdomen in someone you suspect has appendicitis might indicate that the appendix has unfortunately perforated.
And the urgency here.
This is an immediate surgical emergency. The spillage of bacteria and inflammatory mediators into the normally sterile abdomen can rapidly lead to overwhelming infection, septicemia, and circulatory collapse, shock. The patient can deteriorate incredibly quickly. Prompt diagnosis and surgical intervention to repair the hole and wash out the contamination are absolutely essential for survival.
Before we delve into the physical examination proper, the text provides that standard framework for describing findings, the 9 regions of the abdomen.
Right. This is just a standard mapping system used clinically to ensure clear communication and systematic thinking. The abdomen is divided by 2 vertical lines, usually the midclavicular lines, dropping straight down from the middle of each collarbone, and 2 horizontal lines.
Which are those horizontal lines again?
The upper horizontal line is the transpyloric plane. It's roughly halfway between the suprasternal notch at the top of the breastbone and the pubic symphysis at the front of the pelvis. Anatomically, it often lies near the lower border of the L1 vertebra. The lower horizontal line is the transtubercular plane, which connects the bony tubercles you can feel on the iliac crests, roughly at the level of the L5 vertebra.
So those 4 lines create the 9 regions. Can you list them?
Sure. Across the top row, you have the right hypochondrium, under the right ribs, the epigastrium, upper central, and the left hypochondrium, under the left ribs. In the middle row, you have the right lumbar, or flank, the umbilical region around the navel, and the left lumbar, or flank. And across the bottom row, you have the right iliac fossa, lower right, the suprapubic region, or hypogastrium, lower central, and the left iliac fossa, lower left. Figure 63.2 in the source text is invaluable for visualizing this and associating common organs and potential pathologies with each region, like gallbladder in the RUQ, appendix in the RIF, sigmoid colon in the LIF, etc.
Having that mental map helps you think systematically, doesn't it? If the pain is reported here, what organs are typically in this region? What pathologies commonly affect them?
It provides that crucial framework for organizing both your history-taking and, importantly, your examination findings. You can describe tenderness or a mass by its region.
Okay, the moment of physical examination. The text insists, quite rightly, that this follows a detailed general examination of the patient as a whole. You don't just focus tunnel-visioned on the abdomen straight away.
Absolutely. You need to look at the entire patient first for clues of systemic illness or problems elsewhere that might relate to the abdominal complaint. Then, for the abdominal exam itself, the systematic sequence is non-negotiable. Inspection, looking, palpation, feeling, percussion, tapping, auscultation, listening. Look, feel, tap, and listen, in that order.
Let's start with those general examination clues the text points out. What are you looking for overall?
Proper patient positioning is key first. They should ideally be lying flat on their back, supine, comfortable with maybe just one pillow under their head. Their abdomen needs to be adequately exposed, typically from the nipples down to the pubic bone, respecting dignity, of course. For palpation, as we said, flexing their hips and knees slightly can help relax the abdominal muscles. You're looking for signs of their overall condition, evidence of recent weight loss or muscle wasting, signs of dehydration, like dry mucous membranes, signs of fluid overload, like swelling in the ankles, pedal edema, pallor suggesting anemia, jaundice, that yellowing, indicating liver or biliary problems, or any unusual skin pigmentation.
And examining areas outside the abdomen is part of this general look.
Vital. Look at their hands. Things like finger clubbing, leukonychia, white nails, palmar erythema, red palms, or Dupuytren's contracture, thickening in the palm, can all be signs of chronic liver disease. In the head and neck, look carefully for jaundice in the sclera, the whites of the eyes. Check the lymph nodes in the neck, paying particular attention to the left supraclavicular nodes. Enlargement there, sometimes called Trézier's sign, can be due to spread from an intra-abdominal malignancy, especially gastric cancer.
And vital signs are, well, vital.
Non-negotiable. Heart rate, blood pressure, respiratory rate, and body temperature provide immediate objective information about the patient's stability and the possible presence of infection or shock. In a non-acute elective setting, recording weight and calculating body mass index, BMI, is also standard practice and important for risk assessment.
Now, moving to inspection specifically of the abdomen, what precise things should you be looking for visually?
A systematic visual sweep is needed. First, look for scars. Their presence, size, and location give you immediate insight into previous surgeries. The type of scar might even hint at the type of operation. Then look at the overall contour. Is the abdomen distended? If so, is it symmetrical, like in ascites or generalized gas, or asymmetrical, suggesting a large mass or localized obstruction? Are there any visible masses or bulges? Can you see vertebral peristalsis loops of bowel contracting visibly through the abdominal wall? This can indicate obstruction, especially in thin patients.
Verticals.
Are there dilated veins on the surface? Prominent veins, especially around the umbilicus, caput medusae, can suggest increased pressure in the portal venous system, often due to chronic liver disease and cirrhosis. Can you see aortic pulsation in the upper abdomen? Is there any obvious abdominal wall swelling that might indicate a hernia, umbilical, incisional, inguinal?
The text highlights some very specific discoloration signs that point to serious emergencies, the bruising signs.
Yes, these are Gray-Turner sign and Cullen sign. They indicate significant internal bleeding, usually retroperitoneal or intraperitoneal. Gray-Turner's sign is bruising, or maybe a faint yellowish-blue discoloration appearing in the flanks, the sides of the abdomen between the ribs and the hip. It suggests retroperitoneal hemorrhage, bleeding behind the peritoneum. This can be seen in severe acute pancreatitis, where enzymes leak and digest tissue, or sometimes with a leaking abdominal aortic aneurysm. George Gray-Turner was a British surgeon who described it.
And Cullen sign.
This is similar bruising or discoloration, often yellowish-blue, appearing specifically around the umbilicus, the belly button. It suggests bleeding within the peritoneal cavity itself that is tracked forward through the abdominal wall layers. It's classically associated with conditions like severe acute pancreatitis, a ruptured ectopic pregnancy, or sometimes significant trauma to the liver or spleen. The mechanism is thought to involve blood tracking along the ligamentum teres, which is a remnant of the umbilical vein connecting the umbilicus to the liver. Thomas Stephen Cullen was a Canadian gynecologist.
These signs are dramatic and significant internal pathology, clearly.
They are, though the text correctly notes they are much easier to see and appreciate in patients with fair skin. You also need to carefully observe how the abdominal wall moves with respiration. Normally, the abdomen rises and falls freely with each breath. In acute pain, particularly if there's peritonitis, the patient will often breathe very shallowly using only their chest muscles, keeping the abdomen almost completely still to avoid exacerbating the pain. Reduced or absent abdominal movement with breathing is a significant sign.
The scaphoid abdomen is another visual clue mentioned.
Yes. In thin patients with diffuse peritonitis, where the whole abdominal lining is severely inflamed, the abdominal wall can appear sunken or concave scaphoid due to the intense, protective, involuntary contraction of the rectus abdominis muscles. They are guarding so intensely it actually pulls the abdominal wall inwards. It looks hollowed out.
A simple, gentle test mentioned is asking the patient to cough. How does that help?
This is a very useful clinical maneuver, often much less painful or startling for the patient than formally testing for rebound tenderness. Asking the patient to give a gentle cough momentarily increases intra-abdominal pressure. If there is underlying peritoneal irritation in a specific area, this sudden pressure increase will cause a sharp, localized jab of pain right over the inflamed spot. It's a gentle way to identify the location of peritonitis.
And a visible cough impulse helps confirm a hernia.
Exactly. If you see a bulge, perhaps at the groin or umbilicus or along a scar, that becomes noticeably more prominent when the patient coughs. That's a positive cough impulse, characteristic of a hernia. The overall contour of the abdomen is also important. In ascites, which is free fluid in the abdomen is typically symmetrically distended, generally rounded, and the flanks often bulge outwards when the patient is lying flat.
The text gives a specific tip for observing masses and peristalsis most effectively.
Yes. To best observe subtle bulges, the shape of masses, or those visible peristaltic waves, the clinician should ideally kneel down or bend low so their eye level is even with the patient's abdomen. Looking tangentially across the surface from this angle makes these findings much easier to spot than looking straight down from above. This position is also often quite good and comfortable for subsequent palpation.
Visible bowel loops in thin patients can sometimes even suggest the type of obstruction.
They can. Sometimes you can almost see the outline of grossly distended bowel loops through a thin abdominal wall. The text points out that if you see a very overdistended, somewhat bean-shaped loop pointing up towards the left upper quadrant, it's highly suggestive of a caecal volvulus, where the caecum has twisted on itself. Conversely, if a similar large distended loop seems to be pointing up towards the right upper quadrant, it's more likely to be a sigmoid volvulus, a twist in the sigmoid colon.
Okay, that's a thorough look at inspection. Now, palpation, actually feeling the abdomen. This is perhaps the most critical part of the physical exam for many abdominal problems, isn't it?
It really is. And it absolutely must be systematic. You need to gently feel all 9 regions of the abdomen that we mapped out earlier. A crucial rule the text emphasizes is to start palpating in the region furthest away from where the patient has indicated their pain is worst.
Why start away from the pain? What's the rationale?
Well, several reasons. First, to assess the less painful areas, establish a baseline of what feels normal for this particular patient's abdomen. Second, to gain the patient's confidence by being gentle initially. And third, crucially, to avoid causing intense pain right at the start, which would inevitably make the patient tense up, guard their abdomen, and make a meaningful examination of any area very difficult, if not impossible. You also need to clearly instruct the patient to tell you where and when they feel any tenderness as you go.
And the technique for palpation itself, gentle is key, right?
Absolutely. Use warm hands if possible. Cold hands can make muscles tense. Approach gently and smoothly. Constantly watch the patient's face for nonverbal signs of discomfort, like wincing or grimacing, even if they're trying to be stoic and not say anything. Start with superficial palpation, feeling just below the surface with light pressure, assessing for tenderness and any muscle guarding. Then, only if tenderness allows, proceed to deeper palpation to feel for underlying organs or masses.
This specific hand technique is mentioned to avoid poking with fingertips.
Yes, this is important both for patient comfort and for getting better information. Your examining forearm should ideally be held horizontally, roughly parallel to the bed. Keep your whole palm and fingers flat and together on the abdomen, applying pressure gently and evenly. The movement for palpation should primarily come from flexing your metacarpophalangeal joints, your main knuckles, rather than bending your fingers at the interphalangeal joints. It's more of a flat-handed, dipping, or gentle sweeping motion, not jabbing with the fingertips.
And palpating during respiration helps feel organ margins moving down.
Yes, particularly for the liver and spleen, which sit under the diaphragm. By placing your hand in the right position and asking the patient to take a slow, deep breath in, you can often feel the lower edge of these organs as they descend with the diaphragm's contraction.
And the text mentions a specific doughy feel sometimes encountered.
This is a specific tactile sensation sometimes described in patients who have ascites, free fluid, due to tuberculosis affecting the peritoneum, tubercular peritonitis. The combination of the free fluid and a thickened, somewhat inflamed peritoneum can apparently create a characteristic soft, slightly resistant, dough-like texture upon palpation. It's said to be distinct from the feel of simple ascites due to, say, liver failure or malignancy.
Let's focus now on those crucial signs of parietal peritoneal irritation that you feel on palpation. What are they again?
These are the signs that tell you the sensitive lining of the abdomen, the parietal peritoneum, is inflamed. Tenderness, guarding, rebound tenderness, and rigidity. Tenderness is simply pain elicited by your pressure during palpation. Guarding is the reflex contraction or tensing of the abdominal muscles overlying an area of inflammation or pain.
And you mentioned differentiating voluntary from involuntary guarding earlier. How do you tell?
Yes, voluntary guarding is conscious and tender. The patient tenses up because they are anxious, cold, or anticipating pain. It might relax if you can distract them or encourage them to breathe slowly. Involuntary guarding, however, is a true reflex spasm of the muscles that occurs automatically when the underlying inflamed organ touches the parietal peritoneum. It feels more sustained, rigid, and doesn't relax with distraction. It's a much more reliable sign of significant underlying peritoneal irritation.
Rebound tenderness also indicates this irritation.
It does. Classically, it's described as pain that is noticeably worse when the pressure of deep palpation is quickly released, rather than during the pressure itself. The sudden movement or rebound of the abdominal wall and the underlying inflamed viscera irritates the parietal peritoneum. However, as the text rightly notes, asking the patient to cough gently or even gently percussing the abdomen over the tender area are often equally sensitive ways to elicit this wincing pain response indicative of peritoneal irritation, and they are usually much less aggressive or distressing for the patient than performing forceful manual rebound testing, which can be quite painful.
And rigidity sounds like the most severe form of guarding.
It is, essentially. Rigidity means the entire abdominal wall feels board-like, hard, diffusely tense, and unyielding. This occurs in generalized peritonitis, where the inflammation has spread throughout most or all of the abdominal cavity. It's basically widespread, severe, involuntary guarding. In these cases, because the entire abdomen is so tense and tender, the selective tenderness that might have been localized over the initially affected organ can actually become less obvious or lost in the diffused picture.
Palpating for abdominal masses requires differentiating where the mass is located in the wall or deeper.
That's a key skill. You need to try and determine if a palpable mass is located within the layers of the anterior abdominal wall itself, or if it's deeper inside the abdominal cavity, either intraperitoneal within the cavity or retroperitoneal behind it. The main technique involves asking the patient to actively tense their abdominal muscles.
How does tensing the muscles help make that distinction?
You can ask the patient to lift their head and shoulders off the bed as if doing a sit-up, or perhaps lift both legs straight up off the bed, or perform a Valsalva maneuver, bear down. These actions strongly contract the rectus abdominis and other abdominal wall muscles. Now, if you can still palpate the mass just as well, or if it perhaps becomes even more obvious or fixed when the muscles are tense, it's likely located in the abdominal wall, superficial to the muscle within the muscle, or attached to the deep fascia. However, if the mass becomes less palpable, indistinct, or seems to disappear completely when the patient tenses their muscles, it strongly suggests the mass is located deeper inside the abdomen, intraperitoneal or retroperitoneal, and the tense muscles are now shielding it from your palpating hand.
That makes sense. And movement with respiration also gives clues about deep masses.
It can. An intraperitoneal mass, one floating or attached within the main abdominal cavity if it's located high up, perhaps attached to the liver or spleen or stomach, might move downward slightly with each deep inspiration as the diaphragm pushes it down. Retroperitoneal masses, those located behind the peritoneum, like enlarged kidneys, pancreatic masses, or large aortic aneurysms, are usually fixed in position and typically do not move with respiration. An enlarged kidney specifically is often described as being palatable, meaning if you push forward firmly from the flank with one hand, you can feel the kidney bounce forward and tap against your other hand placed on the front of the abdomen, and it's often bimanually palpable, meaning you can feel its shape and size reasonably well between your two hands, one pushing from the back and one feeling from the front.
And what about feeling for aortic pulsations? How do you interpret those?
Well, in thin individuals, it's quite normal to see and feel the transmitted pulse of the abdominal aorta in the epigastrium. That's not necessarily abnormal. However, feeling an expansile pulsation where the vessel feels like it is actively widening or expanding outwards, pushing your fingers apart laterally with each pulse, is highly suggestive of an abdominal aortic aneurysm, AOA, which is a dangerous ballooning of the aorta. It's really vital to distinguish this true expansile pulsation from a merely transmitted pulsation. A transmitted pulsation occurs when a solid mass, like a pancreatic pseudocyst or a tumor, is just sitting on top of a normal-sized aorta, and you're simply feeling the normal aortic pulse being transmitted upwards through the overlying mass. The mass itself isn't expanding.
The technique for palpating organ edges on inspiration sounds quite specific. Can you describe that dipping method?
Yes, it's the standard method for trying to feel the lower edges of the liver, spleen, sometimes an enlarged gallbladder, and the kidneys. You place your examining hand flat on the abdomen, usually slightly distal, meaning below the anticipated location of the organ's lower edge. You then apply gentle but firm downward pressure and hold your hand steady in that position. Then, you ask the patient to take a slow, deep breath in. As the diaphragm descends during inspiration, it pushes these organs downwards. If the organ is enlarged enough to come below your hand position, you should feel its edge gently slide or bump against your fingertips as it passes. If you don't feel anything, you relax your pressure slightly, move your hand a centimeter or two higher up the abdomen, and repeat the process with the next deep breath, gradually working your way up towards the costal margin until you either feel the edge or determine that it's not palpable below the ribs.
Are there any specific clues for pelvic masses in females based just on abdominal palpation?
If you can palpate a mass rising out of the pelvis into the lower abdomen, but you cannot get your fingers underneath its lower edge to define its bottom border abdominally, it strongly suggests the mass is truly arising from deep within the pelvic cavity. Furthermore, if you can move this pelvic mass somewhat from side to side, transversely, with your hand on the abdomen, it's likely originating from the uterus or one of the ovaries, as these structures often have some degree of lateral mobility.
And a mesenteric cyst has a characteristic movement too.
Yes, the text mentions that a cyst within the mesentery, the tissue that anchors the intestines, typically has mobility primarily in a direction perpendicular, or at right angles, to the line of attachment of the root of the mesentery itself.
Let's briefly revisit the specific techniques for palpating two key organs, the spleen and the liver. How do you approach the spleen?
Okay, the spleen is normally tucked up under the left ribs and is not palpable in healthy adults. If you can feel it, it's almost certainly enlarged, splenomegaly. When enlarged, the spleen tends to grow downwards, forwards, immediately toward the umbilicus. To palpate for it systematically, the patient should be supine and relaxed. You should start palpating gently way down in the right lower abdomen, far from the spleen's expected position, with your fingertips pointing upwards and slightly inwards towards the left costal margin, following the spleen's likely path of enlargement. Ask the patient to take a deep breath and feel carefully for the spleen's edge, which often has a characteristic notch you might feel as it descends to meet your fingers. If you don't feel it on the first breath, move your hand a little higher towards the left upper quadrant and repeat with the next deep breath, gradually working your way up. If it's still not palpable with the patient lying flat, you can try turning the patient onto their right side, right lateral position. This uses gravity to bring the spleen forward and downwards and can sometimes make a marginally enlarged spleen palpable when it wasn't felt supine.
And the liver palpation technique.
For the liver, the patient is supine. You place your hand, palm down, flat on the right side of the abdomen, usually lateral to the rectus muscle, with your fingers pointing upwards towards the right costal margin, but positioned below where you expect the liver edge to be. Again, ask the patient to take a slow, deep breath in. If the liver is enlarged enough to extend below the costal margin, you should feel its firm edge descend and make contact with your fingers. As you feel it, you can assess its consistency, smoothness, and whether the edge feels sharp or rounded. You can walk your hand up incrementally with each breath to define exactly how far below the costal margin it extends.
Okay, that covers palpation thoroughly. Next in the sequence is percussion tapping on the abdomen. What information does this give you?
Percussion is primarily used to help distinguish between different causes of abdominal distension. It relies on the principle that tapping over gas-filled structures produces a resonant drum-like sound, tympanitic, whereas tapping over solid organs, solid masses, or areas of fluid produces a dull sound.
So how do you use this to map out areas of dullness, maybe from a mass or fluid?
The most effective way is to percuss by moving your finger from an area you expect to be resonant, like over gas-filled bowel, towards an area you suspect might be dull. Feeling or hearing that distinct change in sound quality from resonant to dull as you move across a border is the most sensitive way to map the boundaries of dullness caused by an underlying solid mass or a pool of fluid.
And for detecting free fluid, ascites specifically.
When the patient is lying flat on their back, supine, gravity naturally causes any significant amount of free fluid in the abdominal cavity to pool in the most dependent areas, which are usually the flanks, the sides of the abdomen. So if you percuss outwards from the center of the abdomen, which is usually resonant due to underlying bowel gas, towards the flanks, you will typically find a transition from resonance centrally to dullness in the flanks where the fluid is collected. This flank dullness is suggestive of ascites.
Which brings us to the classic clinical test for confirming ascites. Shifting dullness. How does that work?
This test is designed to confirm that the dullness you found in the flanks is indeed due to mobile free fluid, rather than, say, a fixed solid mass. First, with the patient supine, you identify and mark the level where the percussion note changes from resonant to dull in the flank. Then you ask the patient to roll over onto their side, say onto their left side. You wait for a moment or two, maybe 15-30 seconds, to allow gravity to cause the free fluid to redistribute and pool on the now dependent left side. Keeping your finger on the mark you made, you percuss again. If the area that was previously dull when they were supine is now resonant because the bowel has floated up, and the area lower down on the dependent side has now become dull because the fluid has shifted there, that confirms the presence of mobile free fluid. That's positive shifting dullness.
There's also the fluid thrill test mentioned. When is that useful?
The fluid thrill, or fluid wave test, is really only positive when there is a large amount of free fluid present, usually quite tense ascites. To perform it, you need the patient lying supine. You place the palm of one of your hands flat against one flank. Then you use your other hand to give a sharp tap or flick to the opposite flank. If there's significant free fluid, you should feel the impulse, the thrill, or wave, transmitted distinctly across the abdomen through the fluid to your receiving hand. It's important to have an assistant, or use the side of the patient's own hand, press firmly down along the midline of the abdomen while you do this. This midline pressure helps to dampen or prevent the vibration from simply being transmitted superficially through the subcutaneous fat and muscle of the abdominal wall, ensuring that the thrill you feel is genuinely traveling through the intra-abdominal fluid.
And the text mentions percussion can also be used as a sensitive test for rebound tenderness, similar to the cough test.
Yes, exactly. Gently percussing the abdomen directly over a suspected area of inflammation can elicit that characteristic wincing pain response that signifies underlying peritoneal irritation. It's another way, often less jarring than manual rebound, to check for peritonitis, especially if direct palpation is proving too painful for the patient.
Okay, finally in the sequence comes auscultation, listening to the abdomen using a stethoscope. What are you primarily listening for?
Primarily, you're listening for bowel sounds. Their presence, their frequency, and importantly, their character can give you valuable clues about the activity or lack thereof of the intestinal tract.
What do bowel sounds tell you in cases of obstruction?
Well, in the early stages of a mechanical intestinal obstruction, when the bowel is still actively and forcefully trying to push its contents past the blockage, you often hear hyperactive bowel sounds. They are typically described as being high-pitched, perhaps tinkling or rushing in quality, and they can be quite frequent and loud. Sometimes you hear prolonged gurgles called borborygmi. This increased activity reflects the bowel's struggle against the obstruction.
And what about in peritonitis or paralytic ileus?
In generalized peritonitis, where the bowel wall itself becomes inflamed and paralyzed by the surrounding inflammation, or in paralytic ileus, where bowel muscle activity ceases for other reasons, like after surgery due to electrolyte imbalances or certain drugs, the abdomen typically becomes quiet. You will either hear no bowel sounds at all over a period of listening, say a full minute or two, or they will be extremely infrequent, faint, and far between. This silent abdomen is a significant clinical sign suggesting lack of bowel motility.
You can also listen for vascular sounds, bruits in the abdomen.
Yes, it's good practice to listen specifically over the path of the abdominal aorta in the epigastrium and the iliac arteries lower down towards the groins. A bruit is a harsh whooshing sound that you hear with the stethoscope bell, caused by turbulent blood flow through a narrowed or stenotic artery. Hearing an aortic or iliac bruit might suggest significant underlying atherosclerotic disease.
And the succussion splash, what does that indicate?
The succussion splash is a very distinctive sound, exactly like shaking a half-filled bottle of water. You elicit it by gently rocking the patient's upper body or abdomen from side to side while listening with your stethoscope over the upper abdomen or epigastrium. Hearing this splashing sound indicates that there is a significant amount of fluid and air trapped and retained within a dilated stomach. It's most typically found in conditions causing gastric stasis or delayed gastric emptying, particularly gastric outlet obstruction, where the stomach simply isn't emptying its contents properly into the duodenum.
Now, the text makes a very important point that the abdominal examination is not truly complete by just examining the abdomen itself. There are essential related areas to check.
This is a critical and sometimes unfortunately overlooked point for ensuring thoroughness and avoiding misdiagnoses. A truly complete abdominal assessment absolutely demands examining related areas, even if the detailed techniques for examining those areas might be described in other chapters of a textbook like Bailey and Love. They are listed here as part of the comprehensive approach.
What are those essential additional steps that shouldn't be skipped?
First, you must systematically inspect all the common external hernia sites, the inguinal canals, for inguinal hernia is very common, the femoral canals just below the inguinal ligament, for femoral hernias, especially important in women and prone to strangulation, the umbilicus, for umbilical hernias, and along any previous surgical scars, for incisional hernias. Missing an incarcerated hernia as the cause of abdominal pain or obstruction can be disastrous.
Okay. Hernias checked. What else?
You must examine the external genitalia. In males, testicular pathology like torsion or epididymitis can sometimes present with referred abdominal pain. The anal region must be inspected visually for external issues like fissures, hemorrhoids, abscesses, or fistulas that could be relevant. And crucially, performing a digital rectal examination, DRE, is required in most cases of significant abdominal pain or altered bowel habit.
What are you assessing with the DRE?
The DRE allows you to feel for any masses within reach in the rectum, assess the consistency of any stool present in the rectal vault, check the stool on your glove for occult or gross blood, assess the prostate gland in males, and potentially elicit tenderness if there is pelvic inflammation, like appendicitis low down in the pelvis, or pelvic inflammatory disease.
And in females, a vaginal exam might be needed.
Yes, a pelvic or vaginal examination is often necessary if the history or abdominal findings suggest potential gynecological causes for the abdominal or pelvic pain, such as ovarian cysts, fibroids, or pelvic inflammatory disease.
You also mentioned examining the back as part of this.
Yes, it's important to specifically examine the renal angles. That's the area between the bottom rib and the spine on each side in the back. Tenderness elicited by firm percussion here, renal punch or Murphy's punch, can indicate kidney pathology like pyelonephritis or stone. You should also briefly examine the thoracic and lumbar spine, checking for tenderness or deformity, as pain referred from spinal problems like a nerve root compression or vertebral collapse can sometimes mimic intra-abdominal pain.
These additional steps really seem non-negotiable for a truly complete abdominal workup, drawing together knowledge from multiple parts of the body that can impact or mimic abdominal symptoms.
They absolutely close the loop on the physical assessment and prevent you from getting fixated only on the abdomen itself.
The final section of this material discusses something incredibly important in practice: the value of observation and review, particularly in those challenging, uncertain cases.
Yes, this addresses perhaps the most difficult and anxiety-provoking scenario in managing acute abdominal pain in the patient, where even after taking a detailed history and performing a thorough initial clinical examination, you are still uncertain whether they truly have a surgical problem requiring urgent intervention or not. The diagnosis just isn't clear yet.
The text candidly states that this is the group where the majority of diagnostic errors unfortunately occur.
It really highlights the challenge of distinguishing true surgical emergencies from conditions that can closely mimic them. Examples given in the text of non-surgical causes of abdominal pain and vomiting include metabolic diseases like diabetic ketoacidosis, DKA, acute intermittent porphyria, or even hyperparathyroidism causing hypercalcemia. Pain referred from non-abdominal sources like a heart attack affecting the bottom wall of the heart, inferior MI, pneumonia affecting the base of the lung, irritating the diaphragm, or pain from spinal nerve compression can also confuse the picture entirely. And of course, functional abdominal pain remains a diagnosis of exclusion in some cases.
These uncertain patients clearly need further urgent investigations, blood tests, imaging, etc.
Absolutely. Scans, blood tests, urine tests are all necessary in this situation to help clarify the diagnosis. But the absolute critical point emphasized by the text is the vital importance of regular review of the patient while you are awaiting those investigation results, or simply observing their clinical course over a short period. You don't just order the tests and walk away until the results are back.
And ideally, this review should be done by the same clinician who did the initial assessment.
That continuity is incredibly valuable if possible. The person who saw the patient initially, who has that baseline assessment fixed in their mind, is often best placed to notice subtle changes over the next few hours. Perhaps a slight increase in the degree of localized tenderness, a worsening of the guarding, a change in the character of the bowel sounds, a subtle deterioration in their general appearance or vital signs, or maybe a significant shift in the location or character of the pain. These subtle changes, detected through repeated examination, can be the crucial indicators that tip the diagnosis decisively towards a surgical problem, or alternatively, reassure you that things are settling down.
And the text is very clear on this point. Such a period of careful, active, regular observation and re-examination is not just passive waiting. It is an integral part of the early management and diagnostic process for patients with acute abdominal pain when the diagnosis isn't immediately clear-cut.
It's active surveillance, it's clinical judgment, vigilance, and the ability to detect change over time, all built squarely on the foundation of that initial thorough history and examination. It's the art of allowing the clinical picture to evolve under a careful, experienced watch.
This deep dive into Bailey and Love's approach has really, I think, peeled back the layers on how expert clinicians think about abdominal complaints. It's so much more than just a checklist of questions and pokes. It's a systematic, deeply informed process rooted in understanding anatomy, physiology, clinical patterns, and human interaction. It highlights the incredible power of careful observation, attentive listening, and skilled physical assessment as the true cornerstone of surgical diagnosis, even in our current age of incredibly advanced technology.
It certainly reminds us that technology is there to supplement, but it really doesn't replace that fundamental interaction and hands-on examination between the clinician and the patient.
So, as we wrap up this deep dive, let's leave you with this thought to ponder. In a world increasingly reliant on high-tech scans and complex lab tests, What does the enduring emphasis in classic surgical texts, like the one we've explored, on truly mastering the detailed history and the nuanced physical examination tell us about the perhaps irreplaceable value of human connection, careful listening, and the refined skill of touch in unraveling the body's mysteries?
Yeah. What subtle yet potentially crucial clues might we risk overlooking if we don't continually strive to cultivate and perfect these foundational, hands-on clinical skills, aiming, as you said, to master them like the elite professionals in the field? What insights might only be found by truly seeing, listening to, and feeling what the patient is telling you, both verbally and nonverbal?
Something to think about.